if we're in a crisis, why don't we sort of tease it apart just a little bit? The most common types of these, by the way, how would you define a nosocomial infection? How would you define it, a nosocomial infection?
I'm not sure that language is necessarily valuable anymore.
Why not?
Because we used to categorize infections classically as either community onset or nosocomial because that gave us information about the pathogens that the patient was at risk for.
Right.
And although that used to be particularly specific, I'm not sure it's very sensitive anymore. And by that I mean pneumococcus remains the #1 pathogen in community-acquired pneumonia if you have pure community-acquired pneumonia. But if you look at patients who present to the emergency room with pneumonia, and then you start dissecting out the pathogens, pneumococcus isn't #1 anymore. If you work in a hospital like mine, where 50% of our admissions to the ER with pneumonia come from nursing homes, the #1 pathogen is now staph or some gram-negatives. Okay. And so where you sit determines where you stand, as I like to say. And so your perspective on answering that question is only valuable if nosocomial really works to segregate the at-risk patient from the non-at-risk patient.
So we're blurring this entire...
Well, and that makes sense, because as the sociology and organization of healthcare delivery has changed, the pathogens have followed the pathways out of the hospital that we've provided them with.
All right, so I asked that for a specific reason, because I want to sort of begin to drill down on hospital-acquired infections first, and with the understanding that some of these pathogens then are out in the real world, such as defining hospitals as not real. We're not even going there. Yeah. Let's use the word nosocomial and use it specifically to say hospital-acquired or healthcare facility acquired infections, and leave it at that. What are the most common types?
So by far and away, the #1 hospital-acquired infection in terms of just prevalence is pneumonia. Part of that reflects that people will hallucinate pneumonia wherever they see an infiltrate and shortness of breath, and it may be heart failure, or it may, which I call Lasix responsive pneumonia. It may be an aspiration phenomenon in the patient who's had a CVA, and it clears up in 2 days, and they don't need antibiotics, they need a pat on the back and maybe a swallow eval. But pneumonia, if you look at all the data sets, whether it's the national, the old national nosocomial surveillance system, the CDC data, everybody reports pneumonia as #1 in terms of just crude numbers, because so many patients are, and every patient in the hospital is at risk for pneumonia.
Okay.
Followed by things like urinary tract infections, surgical site infections, occasionally hospital-acquired intra-ab, which tends to be secondary or tertiary peritonitis. It's really a failure of initial surgery that's super infected. It's not really a hospital-acquired. And then bacteremias, whether they're catheter-associated or secondary to some other process like the pneumonia or the skin infection itself.
But to be fair, the UTI is the second most common, which I agree with if you look at any data. It suffers from those same limitations, is that any catheterized patient, if you get a urine culture, it's positive and all this, and if you have one non-specific infection sign or symptom that you can't attribute to something else, you've now met definition for CODI, right? And so it's the same problem. The diagnostics really blur the lines on these numbers.
And just for the record, I can't believe I'm going to be nice to my surgical colleagues, but I will. An infection in a hot belly post-op is not necessarily a surgical failure.
No, not at all.
Sometimes that just happens, right?
Oh, right, or right. It could be surgical failure. It could be just happens. It could be lack of source control. It could be ischemic bowel that had nothing to do with the primary surgery. Lots of reasons.
So we have a lot of MDR pathogens, but we have some new therapies. Why don't we just list, if you will, some of the MDR pathogens for which we have new effective therapies or newer effective therapies?
So the good thing is, I think with more focus on resistant organisms and resistant infections, there has really been a focus nationally as well as internationally on the development of new antibiotics over the last 10 years. And so we have seen more development of antibiotics than we were seeing before. And so there's been a lot of excitement around that. Unfortunately, if you look at it, a lot of them really have been developed to treat MRSA infections. And so most of the new antibiotics that we've seen up until the last couple of years were targeted in the gram-positive arena. Meanwhile, we are continuing to see increases with gram-negative multi-drug resistance. However, in the last 2 years, last 2 to 3 years, we have had 3 new agents developed for the treatment of multi-drug-resistant Pseudomonas, as well as carbapenem-resistant Enterobacteriaceae. So we are now starting to see more excitement on the gram-negative side of things as well.
You actually pronounced Enterobacteriaceae. I love that.
And one thing that I'd highlight too is one of the things that I found pretty exciting regarding new antimicrobials or new therapies in general is that some stuff has come out in the C. diff space as well.
That's true.
It's not here per se an MDR pathogen, but that is a disease state that we've had 1 or maybe 2 therapies for the longest time, and we've had some new agents there too.
And we've got some new evidence from new drugs from MRSA too, right?
Yeah, absolutely.
Yeah.
Yes.
So it's not all hopeless.
Well, but the question is, with all of these novel agents, no one of them is a cure-all for all of our dilemmas. And in fact, I think it's spurious to believe that we would find a cure-all, right? Because I don't want someone to create for me the antibiotic that's going to kill everything up front so I can be decerebrate in my antibiotic prescribing, because that's how we got into this mess in the first place. I think the important thing to realize is particularly among the newer agents for the gram-negatives, whether it's Zerbaxa, Vabomere, Avicaz, they all have unique strengths and weaknesses. They all have trade-offs that have to be contemplated. They all have different spectrums of activity, and not one of them is going to be the right answer for every hospital. You have to be thoughtful in looking at these agents and decide, do they offer me a benefit, or is there a role for it at my hospital? Does it fit with my concept of antimicrobial stewardship? And it may be no, they don't, and it may be yes, they do, and it may be some do and some don't. But it's one of these issues where you actually have to do a lot of thinking and cognition to decide how you're going to utilize these on your formulary, if at all.
But don't you think that that decision is no longer at the individual physician level? It's managed by a stewardship program.
And we're going to get to that too.
Okay.
But I mean, since you bring it up, I think it is worth at least touching on this right now.
Yeah.
There is the ancient catch, if you will, the catch-22. I'm sitting in front of a patient. That patient has this bug. This drug is great, kills everything. I want to give my patient the bug juice that works, all right? But then I say, well, wait, I've got this responsibility to society as well. And there's got to be a way to reconcile these two, right?
So it's a societal problem, but most of the time you're prescribing in the moment. You're not thinking about the impact on
Well, that's my
society.
point.
And so it's really hard. It's called the behavior change of antimicrobial stewardship. How do you change behavior of what we've done for decades? And that, to me, is the biggest challenge of a stewardship program. Understanding how to change behavior, because that is the million-dollar problem.
I know I'm not going to change my behavior. All those
We're
other
gonna
guys
try.
can change theirs, because I'm going to do what I like to do. Or at least that's what you hear, right?
Right.
And I think we'll get into this a little
We
bit
are.
later
We're gonna
more,
get into
but I think that just kind of the different perspectives is a huge thing to appreciate, because that's why your stewardship program has to have all of these key players on it. It can't just be ID and pharmacy that's making these decisions or these
Okay.
rules.